There were about 6 questions that at least 10 of y'all missed. So I might spend a little more time on those questions. Just as an alert, the next one is May 27th. The next board review is May 27th, and it will be infectious disease. So the first question, which many of you got, but let's look at this question from a breakdown, a question standpoint by looking at answers, because it's pretty straightforward on the one hand, but I think it serves as a great question that if you didn't know, how would you look at this question and look at the answers and at least increase the odds of you getting the question right if you didn't know the answer to this? First of all, this is a 9-year-old, and she's had problems for 6 months with a negative culture. Now, if you were going to repeat the urine culture, then the stem of the question should have some white cells in the urine, which she does not. So A comes off the bat. B is the right answer. We'll come right back to it. Serum complement, for that to be the right answer, all things considered, then you would need to have protein in the urine. And the fact that protein is not there would make complement levels more than likely not be the next study to perform. Measurement of serum immunoglobulin A. Well, really, what's behind the curtain on that particular answer? Well, you've either got a low serum immunoglobulin A or a high serum immunoglobulin A. Within the context of this question, I'm not sure a low serum I could connect a low serum immunoglobulin A, but I could connect a high one because in Henoch-Schoenlein purpura, a serum immunoglobulin A is elevated. So if you knew that just as a database, then you've got to connect back to the stem of the question and say, are they looking for HSP? Well, certainly HSP can have red cells in the urine, but look at the rest of the question. Is there anything that pushes you? Is there a rash? Is there, and look at the abdominal pain. Look at the key word lower abdominal pain. Okay, so again, if it's going to be abdominal pain, classically, that would be at least mid-abdominal pain, upper abdominal pain, if you want to play the game of HSP, not to mention that it probably ought to have protein in the urine also, if you really had significant HSP. The renal ultrasound might be your next best answer, for your second best answer within the context of this question. But again, look at lower abdominal pain. Now, had they said renal and bladder ultrasound, that would made it a little more sticky for me. But the renal is upper. You're looking at the kidney, you're looking upper. And when they tell you lower, that moves you away from the kidney. Hence, why would you answer that question with a renal sonography? I understand that a renal ultrasound can be done as part of a workup of hematuria. I got it. But the way the stem, this is why I wanted to look at this question with y'all and look at how that word lower comes to play here. You just can't skip that word. That adjective means a lot if you didn't know the answer. The classic answer is calcium to creatinine. It's microhematuria. It's been there for 6 months. Blood is irritating to the urethra, irritating to the bladder. Blood in the urine gives you the burning and gives you the lower abdominal pain. So again, if you really didn't feel like you knew the answer, if you went to this question and broke it down, look at the answers. Now, I'm not going to go through every question like this, but I think this one serves as a great example for you to look at questions and realize the words that are there and try to help you use some of those words to at least rule out the other answers that are before you. So the answer on this is B. Next. Number 2, a lot of you missed this question, so let's look at that from a standpoint of database. 3-year-old had stable grade 3 stable reflux of the right ureter, and now she presents with a temp and flank pain. Findings on physical exam are unremarkable except for the right costovertebral line. So I know you're reading this, well, she's got pyelonephritis. Okay. The most appropriate imaging to confirm. This is a database. What is the most appropriate image to confirm? The word confirm. Well, they're asking what is the most sensitive test to diagnose pyelo, short of sticking a needle in the kidney and getting pathology. And this is it's a DMSA scan. A DMSA scan is the scan for pyelo. I suspect a lot of you put renal ultrasound, not a bad answer clinically. Got it. But if you want to confirm, a renal ultrasound does not confirm pyelo. It may set you up to say you need to be concerned for that, and it is the cheap test and it is the least, but the way the question most, confirm, you have to use those words. And if your database knows that DMSA scan is the scan for pyelo, a DTPA can be, it's another renal scan, but that's not for renal involvement of the pylons. That has to do with flow. Remember, there are lots of renal scanning radiopharmaceuticals, Hippurant, MAG3, glucoheptanate, DTPA, DMSA. All of those are radiopharmaceuticals, and they each have their own special need. Are you looking at flow? Are you looking at function? Are you looking at vascularity? Are you looking at infection? And if you're looking at infection, it's the DMSA scan. So I can understand, don't feel bad if you put renal ultrasound, I got it. It's not totally inappropriate, but it doesn't match the stem of most and confirm. So the answer is B. Next. 17-year-old, sexually active, increasing scrotal pain, tenderness of the right testes elevated, shows many white cells. What's most likely diagnosis? Again, I think most of the people got that. This would be 17-year-old sexually active. He's got epididymitis. What other would you pick there with his fever, etc.? Because a lot of them don't have fever. I guess prostatitis would be next. But then I'm going to need something a little more pushing me into the perirectal region. I would need that this kid was probably gay and having some sort of, I just need more for that being the second best answer. But this is kind of a classic epididymitis. 4. Newborn nursery. Most of you, I think, got this. This is the classic of oligohydramnios. You're set up for a kidney problem. Undescended testes, a mega urethra, palpable kidneys, and the palpable kidneys are hydronephrosis. Remember, this is a functional hydro as opposed to an anatomical hydro. And the absence of musculature, I mean, I don't know what else I can help you here, is that you've got to know the syndrome. This is the classic prune belly. The Potters would be dysplasia or absent kidneys, so that goes away. The posterior urethral valves might be a good thought in the fact that, you're set up for this, but when you see the absent musculature, it just goes for prune belly syndrome. Number 5. A 15-year-old red urine football. I think most of you got this. I mean, even as you just read the first question, your mind should be going to, myoglobinuria, but it could be something else. He could be in renal failure from, heat intolerance, yada, 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 just the first line. So then it goes on and you have blood 4+, but no red cells. And I think everyone, knows that that's going to be myoglobinuria. Football being a classic, he's an athlete, could be something else. There's another question in here that reinforces this. I think y'all are pretty good on getting this right. 6. Diagnosing a UTI on a 14-month-old. She's got fusion of the labial. You know that that's a setup for a girl. For a male in the first year of life, it's whether they've been circumcised or not. So that the setup for this UTI, the preferred management is the application of estrogen cream. You certainly wouldn't do it orally. You wouldn't put her under anesthesia. You might have to get there to lyse the adhesions if your preferred management didn't work. The manual lysis can be done of the adhesions, but that's not preferred. And then surgical this is a question where genital exam under anesthesia negates surgical lysis. I mean, those two go together, hence they can't be the right answer. And so you can eliminate those two by just test taking skill sets. Now, if you go to, if they had put steroid cream down there, I'd have had a little trouble. because you can use some steroid cream and estrogen cream. That would have been hard for me the way that went. But the fact that it's not down there makes it a moot point. So the answer is B, application of the estrogen cream. 7. This is a kid with nephrotic syndrome. You know nephrotic syndrome. Albumin's low. You know that the C3 is okay, as it should be. He's got the proteinuria. Sometimes you have to give furosemide, depending on the clinical situation, to help mobilize the fluid. And then he gets abdominal pain, hematuria, and hypertension. Now, the classic with a nephrotic in this question, which doesn't include it, would be fever. If they'd given you fever, you know the classic answer is occult pneumococcal peritonitis. But he doesn't have fever, so you're not going there. Then you have to look at what are the other potential side effects of nephrosis when they really have a lot of volume, intravascular volume depletion. They lose their anticoagulants, so they're set up for thrombosis. And with the hypertension, the hematuria, because, you know, classic nephrotics don't have hematuria. I know, 10% can, I got it. But I'm not sure they would have 100 red cells per high power field. So your classic dehydrated patient, and this could be a little kid who's not nephrotic, but really dehydrated, you're always set up for thrombosis and an RVT, renal vein thrombosis, especially in a nephrotic is what you see with the hypertension and whatnot. So that answer is going to be E. Next, 15-year-old presents with flank pain, short stature. You've got kind of a creatinine that's okay. The electrolytes are okay, except for the metabolic acidosis. And you know, when you see that right off the bat, you just go ahead and say, what is the anion gap, and figure that out right quick. He does have some hematuria, microhematuria, but he has the renal calcifications. And so when you do this, this is going to be an RTA. Which one has the bilateral renal tubular calcifications? That's going to be your distal RTA. So that answer is going to be B. The proximal typically doesn't, and that's going to have other things in the urine and classically hypophosphatemia. And this patient has a normal phosphorus. So to get into a proximal tubular like a Fanconi's, I don't know what the vitamin D intoxication would be in the sense that if that's the case, then you're going to have either one of too much calcium or phosphorus, which you don't here. Cystinuria, why would cystinuria present at 15? Well, it could. Now remember, this is cystinuria, not cystinosis. So had cystinosis been there, if you were a test taker, you would understand that cystinosis and proximal RTA cannot be in the same answer because they both go together. But this is cystinuria. Cystinuria is kidney stones. So the kid could have hematuria and have kidney stones, but they wouldn't be in the, and really they probably should have said, when they say renal calcification, they could have said parenchymal renal calcifications, because the cystinuria would have the kidney stone in the collecting duct. And then you'd still have to come back at me and say, well, why does he have a metabolic acidosis with cystinuria? So it just doesn't fit. And then you're set up with the short stature, that if you know that those are distal RTAs, those kids don't grow as well. So there are lots of things that set you up for the right answer. Primary hyperparathyroidism, that's the short stature. They're teasing you there, but of course, if you had that, you're going to have an elevated serum calcium, which the patient doesn't have. So answer B, distal RTA. Next, number 9 is a 6-year-old with T-colored. You know T-colored is upper tract blood as opposed to lower tract, which is hematuria. Bright red blood, if you can see it grossly. And so, you know, this is going to be upper tract disease. He had an a URI, not a UTI, a URI. He's had it recurrently. You just start putting these things together. His blood pressure really is okay. Okay, a little temp, nothing exciting. He has no rash. Serum complement's normal. The most likely finding is Well, if you look at this and you go through it, and I think most of you got this answer right, this would be your recurrent hematuria with a viral illness, and that's going to be your IgA nephropathy or your Berger's disease. To make it post-infectious, that would be not a bad answer, okay, but the complement level is normal. That answer comes out. Once again, you have to look at things to make it fit the answer in toto. Thin basement membrane disease, okay, we can go with that in the sense that that can have hematuria, all things being equal. So not a bad answer totally, but that typically is not going to be T-colored. That's just going to be hematuria. So the T-colored puts you into the red cells are coming through the glomerulus and they're being lysed or something's happening up there. So it puts the pathology at the level of the kidney. Idiopathic hypercalciuria, we just went through that. That would be the red cells, but it wouldn't be T-colored. It would be either microscopic or bright red because that's post-glomerular, if you will. So all things considered here, the hereditary nephritis, you know that you're going to not have this kind of recurrent infection, and that should be, it is a boy, so you got to get looking at the gender there. The complements are normal, so you could set me up, but the lead in here with this recurrent infection, the fact that he has normal blood pressure, you're just going to have to move away from the Alport's hereditary, no family history here. It just doesn't reek that this is going to be no hearing loss. You know, if they want to go with an answer like that, there generally is something else in the stem of the question that supports that being the answer. So once again, a good test taker looks at this and says, well, what's not there? Hence, that's not the answer. You know, again, that's if you had no idea of what the answer would be. So this is going to be Berger's. 10, 2-week-old infant is being seen, routine health, has a distended abdomen, bladder can be palpated. The mother's noticed that urine dribble. Well, here's the dribbles is the key word. And a 2-week-old newborn who dribbles, just don't even go any further. That's the posterior urethral valve. That's, and a lot of y'all miss that. I say, well, let's then go through this. There's a distended abdomen, but not loss of abdominal musculature, ergo prune belly. A urethral diverticulum, not bad, not bad. Maybe it dribbles with urethral diverticula, but why is the abdomen distended? Why can you palpate the bladder if it's a urethral diverticulum, not a urethral stenosis, okay, which would be different. Now, you're going to say, well, now, wait a minute, Dr. Starr, look at D, urethral meatal stenosis, okay? Not bad answer there, to be honest with you. That would not be an inappropriate answer for those of you who answered that. The urethral stricture, okay? Do you see how all of these things are kind of common, if you will? And the fact that all of those are kind of together make it be any of the potential answers could be thought about, but I'm just telling you, this is a pattern recognized question. You know, remember I tell you about pattern recognizers. If you see salmon colored rash, answer JIA, I don't care what the question is. If you see neonate dribbles, it's posterior urethral valves. I really don't care what the question is. So in truth, this is a tough question because other than the prune belly syndrome and the urethral diverticuli, the D and E are not bad answers, all things considered. But when you get into the pattern recognized word of dribbles is urine, you know, it's just posterior urethral valves. I don't know what else I can tell you. So just remember some of the pattern recognizers as you come through. Number 11, You are evaluating an 8-year-old in your office with fever, abdominal pain. She's got a temp, soft abdomen without flank or suprapubic tenderness. Your analysis are negative, but she's got protein. So they're pushing you all the way away from the kidney, right, as being the cause of the fever. No flank pain, no suprapubic, not the kidney, not the bladder. And she's 8, so you're going to have a little trouble if you tried to jump into a urethritis diagnosis. And of course, she doesn't have white cells in the urine anyhow, so all she's got is protein 2+. And you remember that the 2+ is kind of an in-betweener, especially if you're dehydrated or if you have a high fever, the answer being high fever. 4+ for nephrotic, collagen vascular needs blood and protein, post-infectious blood and protein, urinary tract needs white cells. This is kind of a no-brainer. Number 12, 18-year-old feels that dragging sensation. I think most of you got that. This is almost, once again, a pattern recognizer. Left side, lays down, goes away. This is a varicocele, end of story. 13, 6-year-old, anasarca, creatinine okay, but albumin is low. The cholesterol is elevated. Whitney, move me up 13. Okay. So she's got, ANA is negative, but her urinalysis has maybe some mild hematuria there. Urine protein's 300. Which is this diagnosis? Well, you got to come back and she's 6 and she has a complement C3 that is normal. So then that's your big stratifier. Please know which of your GNs is a hypocomplementemic and not, okay? I mean, that's one of the major stratifiers here. Membranous, hypocomplementemic. Membranoproliferative, hypocomplementemic. Post-infectious, hypocomplementemic. SLE, hypocomplementemic. Minimal changes, not. Hence, this is going to be the answer, okay? Now, I know that not all membranous are necessarily hypocomplementemic. I got that. But within the stem of this question, you've got to get, if you want to play that game, which is fair, say, well, now wait a minute here, is this one going to be one of those that isn't? Then you look in the stem of the question for the other element that'll push you there. What would be the other element for membranous? Well, it classically is associated with hepatitis B. Now that's a database. If you don't know that, it doesn't help you. I got it. But if you do know that, then the fact that it's not there pushes you away from that. SLE, if you want to play that game. Well, the C3, it's more C4 with SLE, and they're trying to catch me by just telling C3. Okay, got it, good, you know that, that's pretty impressive. But the ANA is negative. Once again, you have to plop away from that. And then you look at that minimal RBC, and we said this a while ago, with 15% of nephrotics can have a little microhematuria, here it is, but with that protein, low serum albumin, obviously high cholesterol, 6-year-old, normal creatinine, it's minimal change. 14, 7-year-old, Coca-Cola colored, all right, once again, Coca-Cola colored, tea color, Coca-Cola upper tract, respiratory infection, edema. Now, this one's hypertensive. This one may have a little renal embarrassment. Her creatinine's up a little. Her C3 is low. Her ASO is high. I mean, you got red blood cells and cast, hello. I mean, I think this is kind of, most of you got this. This would be your classic post-infectious GN, okay? So 14 is answer C. Next. 10-year-old presents for annual sports participation. Father has renal failure, uh-oh. Now the blood pressure is elevated on him. He does have some microhematuria. His creatinine though, 0.7, maybe 10-year-old, just a little, nothing I can write home about. Renal ultrasound though shows large kidneys and cyst in each. Well, with the father, you know that this is just reeking of the fact that you have got autosomal dominant polycystic disease A. Remember, recessive, much younger. Juvenile nephronophthisis is micro cystic disease. Medullary sponge kidney would be unilateral. Multicystic dysplastic kidney would be unilateral. So if you're looking at cyst in kidneys, my discriminator is number 1, unilateral, bilateral. Number 2, macro or micro cyst. And there you go. And then that gives you your differential within the stem of the question right off the bat. Okay? So that's a database for you to know, unilateral versus bilateral. I mean, I know that, but at least look at it. If you can apply your database to those 2 stratifiers right quick, it miraculously increases the potential for answers when you're into cystic disease of the kidney. And you're here because they tell you there's renal cyst. Okay, 16. A lot of you missed 16, so let's look at this. 14-year-old boy, sports physical, everything copacetic, he's cool, blood pressure okay, everything's fine. He has that 100, 2+, spot urine creatinine is 1, urine culture's negative. Now, they don't tell you when, but of the following, the next best step. Well, certainly this protein to creatinine ratio is not normal, but everything reeks about this patient being healthy. So what is your next step? Well, the really next step is to say, what do you think the diagnosis is when he's got kind of a 2+ protein, everything being equal? And the logic is that you could do a 24-hour collection, but remember, the 24-hour collection, unless you do it into 2 aliquots, doesn't help you with the most likely diagnosis of BOP, benign orthostatic proteinuria. And so you want to do orthostatic urine collections. So there's the tease out if you answered E. E will give you the protein. It's going to be abnormal in a 24-hour. You already know that for the protein creatinine. You would have loved to have had this question say in the afternoon. They don't, but they didn't say it was in the morning either. And so that's what you do. Orthostatic urines, his protein, he has none in the morning. He's got this in the afternoon. You know your diagnosis with the physical exam being totally normal. This is BOP. He doesn't need a kidney biopsy. He doesn't need any blood work done. He doesn't need a renal ultrasound. There's no, renal ultrasound. There's no blood in the urine. It's just the protein. So once again, the answer is C. Next, an otherwise healthy 7-year-old, small amount on the blood panties. The girl denies anything. Now, you have to believe the question. You can't play the game is, well, they're saying there's no sexual abuse or trauma, but there really is, and they're not telling me. No, I know your brain should jump into child abuse or sexual abuse. I got that. But when the stem of the question on a test says there isn't any, unless there's a qualifying question later, statement later within the stem of the question, you take it at par. You take it that, okay, it's not. She has this donut-shaped erythematous mass. I really think they should have said African-American. That would have been the tip-off because that's who gets this. Classic 6-year-old African-American girl with this. This answer is urethral prolapse. End of story. That's what it is. There's no you can't, it's just classic. Had they put the African-American, it would really just seal the deal. But based on what you're seeing here, this would be the classic answer of a urethral prolapse. This may be a new entity to you. You need to read this about this because this is kind of in that GU world of the being sure they're going to ask questions in Gen Peds because this is a Gen Peds. Knowing, the varicocele, the testicular torsion, the hernia, the hydrocele in the male. In the female, the labial adhesions, the urethral prolapse, the imperforate hymen, those are some of the classics you need to know from the Gen Peds perspective. So this is urethral prolapse. 18. All right, 1 month ago, had edema of the face, hands, had some little more red cells, 4+ protein. He was diagnosed with nephrotic syndrome. Okay. Now he's Cushnioid. So he's getting the drugs. That's what that's trying to say. And yet he hasn't responded. So this is a nephrotic who's not responding to steroids. So now you've got to think, well, why would that be? And what is your classic diagnosis? All things considered, it shouldn't be minimal change. They respond. He doesn't have post-infectious glomerulonephritis, right? Because he should have had Coca-Cola-colored urine or something along those lines, correct? You don't treat that with steroids, so that wouldn't be it. HSP, okay, got some red cells. Where's the rash? Where's the rash? So he doesn't have HSP, and many times HSP will respond to steroids, but not always, so point well taken. He might be a little old. I just don't see anything else that pushes me to HSP, but FSGS is your classic nephrosis in a 10-year-old or adolescent male that doesn't respond to steroids. And so this is that just the age and the fact that he's not responsive and he's nephrotic and he has a little red cells in his urine. This would be a classic FSGS. So the answer is A. 19 of the following, the patient most likely to develop chronic renal failure. Well, this is database, you either know it or you don't. But, you know, HSP that's persistently nephrotic, that's a bad sign. Because HSP should go away. They may have a little microhematuria, but it ought to go away with treatment or with time. When they become persistent in their nephrosis, that's your bad boy. Unilateral cystic kidney, everybody, most of you got this, so we won't spend any time. Number 20, results of routine urinalysis on a 10-year-old. Okay, well, 2+ blood, negative 10 to red cells, so there's some hematuria, no white cells, but he doesn't have gross hematuria, so it's microhematuria. It's a routine, please look at the word routine urinalysis, okay? He doesn't have anything really. There's no family history. He's not taking any medicines. Vital signs are normal. Physical of the father, the most appropriate next step is. Well, what do you think? I mean, is this not reeking of normal? But he does have the microhematuria. As you know, that could happen with a March hematuria. I mean, he could have been real active. He could have had a little trauma. Yeah, you could do a calcium to creatinine on the urine, not bad, but he has no symptoms for that diagnosis. You're not going to jump on this blood work, and you're not going to do big kidney work, and you're not going to refer to a urologist. More than likely, with him being normal, you're just going to repeat the urine in another week. If it's still there, now you're going to say, now, wait a minute here. And then some of the things that you might want to do for the workup of hematuria, including the calcium creatinine ratio, which would probably be first, would be the next thing to do. Okay. But with this at first blush for a routine urine, you're just going to repeat it and be sure that there isn't, you know, something that just, oh, by the by, happened to present itself because he fell on the jungle gym or whatever. Okay. So remember, a Gen Peds exam, they do tend to be a little more conservative, especially when they are describing everything in the possible that would be causing it is normal. Don't try to make it be something that's not. Okay. A 10-year-old, if you want to say, well, what about Wilms tumor? We wouldn't want to miss Wilms tumor. True. Well, he's a little old for that. It's not going to make any difference in 2 weeks. He doesn't have any pain. I know he's having no trauma, so that kind of negates what I just said. But it just may be the fact that he was exercising or running a whole lot, and you can have a little bit of hematuria, or there's your thin basement membrane. Although you know that thin basement membrane is autosomal dominant, meaning there's no history of renal disease, but that doesn't mean a parent may not have it. It doesn't really give you any. It's a non disease. So, for example, if you repeated this in 2 weeks and it was still there and everything else was equal, one of the answers could be get a urine on the parents. and they may have it, and this is just thin basement membrane disease. So you see my point, hopefully. All right, number 21. A lot of y'all missed 21, so we may need to spend a little time. Soon after birth, the infant develops severe respiratory distress, prenatal ultrasound, markedly enlarged kidneys, oligo, you know, it's a kidney problem, minimal bladder. After birth, he's got enlarged kidneys with diffused increased echogenicity, but no visible cysts. You suspect the child, they go ahead and tell you. Again, a slow test taker would have covered to look down. What are they going to ask? Because as you're reading this, you're probably thinking, oh, this is autosomal recessive, and you may be right. Well, they'll go ahead and tell you that. The most common associated anomaly of this. So this is a database question. See, this isn't figuring out from a stem of the question what they most likely have. This is strictly a database because they tell you what the kidney has, what the patient has. So you just have to know what goes with that. And this is Carolis, if you want to look up an eponym, and it's hepatic fibrosis. Those other things, pancreatic cysts, cerebral aneurysms, go with autosomal dominant. The UTI is neither here nor there. The urolithiasis is neither here nor there. So the answer is hepatic fibrosis, and that's Carolis disease. So that goes with autosomal recessive polycystic disease, not dominant. Dominant has cyst in other areas, cyst in the ovaries, cyst in the pancreas. You get the drift, and your cerebral aneurysm. 22. Previously healthy, comes in, generalized edema, 4+ protein. Okay, maybe hematuria, really, maybe not. Otherwise, everything's fine. Albumin is low. Once again, you know what he's got. He's classic age. He's nephrotic syndrome. This is where you have to look at the suspected diagnosis with this if he has fever and a tender abdomen. And this is your classic occult pneumococcal peritonitis. They do have a little increased instances of UTI. So in fairness to the Pylo answer, but he's got a tender abdomen. They don't talk about costovertebral angle tenderness. Had they said UTI, now that'd have been a little problem for me. But they specifically say Pylo, so that should match up with not just abdominal tenderness, but costovertebral angle tenderness. They don't give you that. And the setup, testicular torsion, he's not the right age for that. Gastroenteritis, well, you know, he's nephrotic. And so the answer is occult pneumococcal peritonitis, A. 23. So you look at these sets of electrolytes, and you've got to interpret the electrolytes. That's all it is. It's just, it's like they gave you a schematic, an Excel spreadsheet, and they're going to do that. And they're going to give you on the left-hand column a bunch of things, and they're going to say up, down, down, up, down as you go across. And they're asking you to process the information so that you understand the physiology of a diagnosis. So here's a set of electrolytes and urine findings, and you have to pick the diagnosis. So you got a little low sodium, a low potassium, a low chloride, and a CO2 that's up. Well, that's a metabolic alkalosis. It can't be an RTA right off the bat, right? Because that's an acidosis. So A quickly comes off. The urine sodium is low and the urine K is high. So you have a high urine K in the face of a low serum K. So you're losing K in your urine, okay? Why would you do that, okay? So if you look at C, congenital hyperaldo, where aldo is holding on to sodium and throwing out K, okay, that would fit. But if you're holding on to sodium, why is your serum sodium low? Serum sodium low. It should be high because you just told me he's got hyperaldo holding on to sodium, and that's not the case. Hence, that doesn't fit. What about pyloric stenosis? Hypochloremic, hypochloremic, metabolic alkalosis, okay, that looks like a good answer. But what is the urine potassium in pyloric stenosis? In other words, why is the serum potassium low? The serum potassium is low not because they're losing it in their urine, but because they're vomiting. So therefore, the urine K would be low in pyloric stenosis. Their resulting serum low K is due to their vomiting. Not the right answer. So now we're down to B and E, cystic fibrosis. Okay, you know you can sweat chloride, sweating, so you could lose sodium and you lose chloride. But CF has nothing to do with potassium. And yes, you can have a metabolic alkalosis because you're trying to respond to a respiratory acidosis. But the potassium would have nothing to do with CF, okay? And why would the urine chloride be high if the manner under which you're losing your chloride is through your sweat? The urine chloride would be low because the sweat's where you're losing it. So that doesn't fit. So by default, the answer is E, none of the above. Now, if you want to know what does this represent, this would represent classic Bartter syndrome. Remember, where you lose potassium, you lose chloride. So it's a abnormality relative to the kidney at the tubular level. So they have loss of, and they can lose a little sodium too. And they're holding on to their bicarb because they're trying to keep their anion gap normal. So this is a classic. This would be Bartter syndrome. Now, if it were Gittleman's, they would have to give you the magnesium to tell you the difference between those. So it could be Gittleman's because they didn't give you, the point is, it's not A, B, C, or D. It's none of the above. 24. Okay, let me look at my clock and be sure we're doing good with time. Okay, yep. All right, a full term is known to have onset of lethargy and poor feeding at 48 hours. The urine smells sweet. They go ahead and tell you it's maple syrup urine. Well, maple syrup urine is an amino acid problem. It's not a fat problem. It's not a carbohydrate problem. So therefore, you would expect ketones in the urine, right? So 24 is ketones in the urine. The glucose in the urine would be galactosemia. They're telling you it's maple syrup. The reducing substance would be the glucose, would be galactosemia. Blood in the urine would not have anything to do with anything. Alkaline pH would have not anything to do with anything. So this is just a classic problem with handling amino acids. And so you are expecting the fats to break down because you can't get your glucose up. Now, had they said hypoglycemia, now that would have been problematic for me, but they didn't. They're looking at the urine. And in fact, they might be hypoglycemic. They're not going to have glycosuria. They don't have any glucose. That's the problem. Hence why they're breaking down their ketones. So the answer is A. 25. Now, a lot of y'all missed 25. So let's look at this. The basics to this is a kid with post-infectious GN. Everything fits. This long stem is all about that. But really the question is, what is the follow-up of in 6 weeks? What would you expect to see? Well, what do we always do to be sure that it's post-infectious GN as opposed to the big mimicker? What's the big mimicker? The big mimicker is membranoproliferative GN. And so what do? You always follow up the complement level, because if the complement level does not return to normal, then you have to say, this might be membranoproliferative. How are you going to make that diagnosis? You have to have a biopsy. The microhematuria can be there for a long time, a year or two. So in 6 weeks, you're still expecting some hematuria. So if it's post-infectious GN, based on what I just said, the C3 should be normal. So you're down to C and D right off the bat. The hematuria will still be there because it can be there for a year or two. C and D still present. The real trick here is the protein, positive or negative. Well, in truth, in your perfect world, in 6 weeks, the protein should be negative. It has gone away. I understand in the real world, there may be still some there. So perhaps this question would have been better to put significant proteinuria.
Dr. Stallworth, Ward's team has a question.
I beg your pardon?
We have a question.
Okay, let me finish and then I'll take it, okay? So that in the fact that the protein is negative, that would be the classic of what you would see. So C is the answer. but I think it would have been better had I talked about significant proteinuria there and it being negative, because you may have still a little, because you know some red cells can sometimes give you that. So all things considered, this question is really asking what's the classic follow-up of post-AGN from a urinalysis perspective. Okay, all right, ask your question.
We thought that the complement levels could still be low up to like 2 months after.
They could. I mean, but they could, but they're doing 6 weeks. I mean, again, if you're going to look at 6, if you wanted that to say 2 months, but really it's 1 to 3 months is the answer. And so 6 weeks falls in that. I think you're right that if you wanted to really be so specific to say that, had I said 7 weeks and 6 days versus 8 weeks, then I'm with you.
I feel like that's a question you get a lot though, because they want to know that you know that just because the complement level is still low doesn't mean they're not getting better.
Okay, but I guess the point, you remember the answer is 1 to 3 weeks. And so you're expecting for post-AGN at 6 weeks for the complement to be normal, saying they are getting better. Am I answering your question?
Kind of.
Okay. Well, I'll never get a good one from you, but I'm doing the best I can. But the real
we'll let it slide.
Thank you. Oh, you're so generous. Okie dokie. So let's move on before the sliding turns around. Okay. Number 26. 3-month-old has growth retardation, polyurethral. Oh, hello. You know, if they're not growing right, there's something bad here. Okay. The creatinine looks not bad. The BUN not bad. The sodium fine. Potassium low. Chloride up. Calcium not bad. Phosphorus low. Uric acid low. Serum glucose okay, but he's got generalized aminoaciduria, phosphaturia, caluresis, potassium, glycosuria. You know this is a Fanconi's, right? And a Fanconi's is a proximal RTA. Thought, well, maybe that'll be the answer, but that's not. They really want to know what is the #1 cause of a congenital, and at 3 months, you'd have to put that adjective in there, congenital Fanconi's, and you've heard me say it 1,000 times, cystinosis. So you're going to do a leukocyte cysteine level, which would be abnormal. Correct? Correct? Is this one okay? Does this make sense? You know I've been over it 1,000 times, right? Are you working with me on this one? Jaya? Hello?
Yeah.
She's feeling okay about it. She didn't want to get up to answer you.
Oh, oh my God. Okay, next. 27, working in the ED in midsummer. All right, it's midsummer, dark urine, no dysuria, flank pain, abdominal pain, fever, nausea, vomiting, blah, blah, blah. Kids on the school track team, midsummer. Why is the summer there? It's hot. Again, sometimes the location is going to, time of year is going to be important. She comes in, moderate dehydration, high specific gravity, 4+ blood, no protein, but only 2 red cells. Here we are again. The answer here, I think everybody got that, with the answer being your myoglobinuria. Now, the exercise hematuria, if you fell for that by reading it quickly, I got it. But where's the red cells? 0 to 2, so you can't call it that. Hemoglobinuria, well, yes, it could do that, but why in this general thing, this would be myoglobinuria, right? So, and again, without any pain or nausea, no kidney stone. Next, 28, 7-year-old brought to the ED, vomiting and diarrhea. She's estimated to be 10. This is Dr. Holloman's question where you have to do the math. You know how to write the fluids, but notice the question, replace the child's deficit. The word, not the 24-hour, just the child's deficit. So you can do the math and figure it out for yourself. We can go over it later if we have time. Anybody that doesn't know the math, but ask one of your peers. But the answer is C, 2,600. If you look at his handout, look in the look in your handbook, just walk through that on how you get a deficit of a 24 kg who's 10% dehydrated. You know, it'll be roughly 2,600. 29, acute renal failure, complains of not feeling well, having butterflies in the chest, arms and legs feel like jello. She's got a QRS that's wider, occasional PVC. What would you administer? Well, what are you going to give this child? Right? I mean, then you have to look at it and say, okay, now wait a minute. What are the symptoms reflecting? And a prolonged QRS, you know that's hypocalcemia. You're going to get them calcium gluconate. Okay? She's got acute renal failure. You know acute renal failure. The calcium goes low, the phosphorus goes high because the kidneys can't hold on to calcium. They can't excrete phosphorus. You get a secondary hyperparathyroidism that can lead to renal osteodystrophy. You ought to know all that's classic physiology, pathophysiology of renal failure, which you should know. If you don't understand anything I just said, I can help you with that, but you need to follow what I just said and have clarity of understanding renal failure. And so the calcium's going to go low. You've got to give them some calcium. You're going to give it slow because you are going to worry about that phosphorus level. And if you give too much calcium, then you're going to throw them into Lot's wife because they're just going to crystallize all over with a high calcium phosphorus complex. But on the other hand, you can't let the heart sit there and get ready to quit on you. So you're going to give the calcium gluconate IV slow. The last question is peritoneal dialysis. It's asking if you understand peritoneal dialysis. And it doesn't get into the weeds with any sort of wildness about this, that, and the other. And this is a classic physics question. And a lot of you miss this question. So you need to get the classic basic, just the basic understanding. You don't need to get into all the tubing and all of the different filters and yada, yada, yada. But you need to have a clear answer about what I would do if a kid was on dialysis and I'm not getting my volume return. So that if I'm not getting my volume return that I should, that means the volume is still in. Hence, it's going to lead to hypertensive, hypervolemia, hypertensive, and or leaking into the third space, edema. So it's classic that this patient is overhydrated and they've got renal failure, they're on dialysis. They're not peeing to get rid of their salt and water. And there's something not working right of helping get rid of that extra volume they have. So what are the things you can do? Well, when it comes to basic dialysis, it's concentration of dialysis, dwell time, frequency of the passes that you do, the ins and outs. Basic it. Don't make this be something that you sit there and tell yourself you don't understand. When you first think about it, it does kind of hit you like, oh my God, I don't understand dialysis. It's really not that hard. Honestly, I'm not saying it because you can do it. You get that mental block. Don't get the mental block. Just back up and say, I can do this. Is basic physics here. So basically what you're going to do on this particular question, if you increase the concentrate in the fluid, it's going to pull the water out because you're going to equilibrate between the peritoneum and the blood. I mean, that's, you know, the body it doesn't hold pockets of stuff. It equilibrates. So if you increase the glucose concentration and you have a serum glucose of, let's say, 90, and you increase the glucose concentration in your dialysate to 250, it's going to pull water to try to make that 250 drop to equilibrate with that 90. You see what I'm saying? So the answer is increase the glucose in the dialysate. You might increase the dwell time also to give it more time to pull the fluid, but that's not an answer. You don't want to decrease the frequency of the dwell time. You're trying to go in and out, trying to get rid of that volume. So D and E for the answer, if they said increase and increase, I'd have a little trouble. The diuretics, well, the kid's in renal failure, he's on dialysis, he's probably not peeing, so they're not going to help you. You don't want to decrease the glucose. So it goes exactly the opposite. So the answer is increase. Does that make sense? So just think logically about physics. You can figure this out. You can figure a dialysis question out. And this would be about as tough a question that you will get on a Gen Peds exam about dialysis, but they want you to classically understand that this is a volume overload, and how you get rid of volume is increase the concentration of the dialysate or increase the frequency of the dialysate, and you could increase the dwell time to give it time to come over. But probably if you did that, you would increase the frequency too. So hopefully that helps. Anybody got any questions? Does that make sense?
All good here.
Oh, wonderful. Any other quick questions? All right, I think we're good on time. Y'all have a good day. I'll work on the infectious disease one for the end of May, as I mentioned. Just let me put a plug in. If you haven't voted for the teacher third year, please do that. Really, this is the end of the week to get that in. I would really appreciate it. All right, bye.